Thank you. So I have a short video and it didn't work, so we're using the computer. And it looks like we'll see if this works. So how many people in the room know what human factors engineering is? Raise your hands. So a pretty educated audience. I'm still surprised, despite a lot of people's effort for 20 years or more associated with medication safety, that a lot of people don't know what human factors engineering is, or they say, oh yeah, that's how the humans screw up the system. So I was asked to give an introduction to human factors, but I'll do that very quickly for this audience, and then we'll talk about some other related things. So I'm a consultant for Fresenius Kabi for the Ivenix infusion system. Probably isn't a relevant conflict of interest for what I'm going to say, but it's relevant to this audience. So the definition of human factors engineering is that it's a formal study of human interactions with tools, devices, and systems to enhance safety, as well as effectiveness, efficiency, and user, and for medical devices, patient satisfaction. And it's been widely applied since the 50s to a wide range of industries. And for this audience, probably everyone has read Don Norman's book, but that's the one I usually use as a recommended introduction. So this is the kind of thing we're talking about here. Fumbling for his recline button, Ned unwittingly instigates a disaster. So, sorry, there was a pop-up on my screen which blocked what I was trying to see. So another technology usability issue. So you can see wings stay on, wings stay off. That's not a good design, right? Everybody agrees with that? So what is a user interface? And actually one of the previous speakers introduced this, so I'll say it quickly. Any aspect of a system, process, or device with which a human can interact. And it includes the recipient of the action. So AI on working on patients, even if you don't have anything to do with it, part of that user interface is with the patient. It includes hardware, software, documentation, labeling, packaging, training, et cetera. And with regard to a medical system, users include clinicians, cleaning personnel, maintainers, patients, lay persons, the shipping personnel who might cut themselves on the device, et cetera. And it's really relevant. This is an old infusion pump that had caused a major harm event where a patient was critically ill and there was a significant delay in therapy because, anybody want to shout out why? They had programmed the norepinephrine, and they inadvertently hit the off button instead of the start button. And this system then had a pop-up, didn't do anything, and a pop-up said, you sure you want to stop? And they didn't see it, and there was delay in therapy. So the take-home message is that the vast majority of adverse events associated with the use of medical technology is due to poor user interface design and not inherent failures of the technology, software and hardware. Now, today, later today, you're going to hear about lots of solutions to our medication safety problem. I view these as tools, and tools can be used well and not so well, and they can be designed well and not so well. And I would argue that none of these current tools are well designed, and technology alone, especially those associated with tools with poor UI design, is not going to solve our problem. You need to take a bigger view. So I want to reframe the discussion of error next, and then we'll talk about systems approaches. So at our institution, we don't talk about errors. We talk about events. And humans always play a role in events. It may be the human on the point of care. It may be very far upstream. But 25 years ago, I stole from nuclear power the concept that any deviation from standard operating procedure is worth investigating. And so we called it a non-routine event. And in healthcare, it's reframed as any deviation from an optimal care path for that specific patient and their outcome, which may not be a return to normal health, but it's certainly, you don't want it to be a degradation in health that it wasn't intended. So there are all these factors that we heard about. Very nice talk from our resident in the last session. We call those contributory or performance shaping factors. And what we study is the occurrence of events usually associated with contributory factors that result in a deviation from optimal care. And when that happens, there's a risk of an increased risk of adverse outcome. And with multiple ones, the risk will get larger. And so what we all do as healthcare professionals is be on the lookout for this. And we look to intervene and rescue or recover to bring patients back to optimal care paths. Giving phenylephrine when the patient's hypotensive is an example of that. And as an aside, a colleague at NASA did a study a few years ago that showed that 20% of all commercial flights, as reported by pilots, have some event that if they didn't detect and do something about, could have resulted in an accident, just to make you feel good about flying home. So I'm going to talk briefly about safety 1 and safety 2. And the fundamental difference is safety 1 mostly is unfortunately after the fact, what went wrong and what can we do to fix it. Safety 2 is about how do people fix systems or make systems work despite all their flaws. So we've studied thousands of cases of non-routine events, and the overall incidence in perioperative space is 20 to 30% of all cases have at least one non-routine event. In our 2007 study, where it's 181 cases that we observed and video recorded, 15% of the non-routine events were categorized as being drug related. Now, the drug may have been the precipitating cause. There are lots of different things, but drugs played a role. In our 2020 study with 512 cases, 13% of NREs were categorized as drug related. And we have hundreds of thousands of video recordings, but hundreds of examples of videos. Like this is just one of them. This is a case where there is clearly documented preoperative lidocaine allergy. And you're going to see in the video, which doesn't have audio just for simplicity, since I didn't think it would work, but it has subtitles, that lidocaine was in fact given during induction. And that's at 7 minutes. And then 11 minutes later is the timeout, which is supposed to prevent problems. And the surgeon says he's allergic to lidocaine, and the anesthesia person snidely says, we'll have to remember that. It was a swelling allergy. So I think Karen may talk about preventing drug allergy or giving drugs for allergy, but that's just an example of many types of intraoperative cases. Now, Dr. Greenwood was very nice to introduce the vecuronium instead of Versed case that was criminalized. And I want to make the point that while there are lots of things that the prosecution pointed to, what I would call active failures of how the nurse in that situation, who, by the way, beforehand was a very good nurse and in fact was busy, was considered good enough to be taking care of a trainee nurse at the time, that they had to leave up in the unit while they did this, but that there were 7 times more latent factors than active failures. And the take-home message here is that improving safety in complex systems requires a different approach than we've been using. So I want to talk more about safety 2. Like safety 1, it's a systems approach, but it incorporates complexity theory and resilience engineering. And it focuses not on that part of the system, whether it's a person or a piece of equipment is broken. Not to say that isn't important, but where you are able to create safety is on the relationships or the communication between the parts. And this is especially problematic when you see local unit optimization. For example, events that are shown to be related to patients that go from the emergency department to the OR, it's the local optimization either in the emergency department or the OR for their priorities that lead to miscommunication, broken relationships, and ultimately to errors. Safety 2 respects clinician expertise and engages them. and thus success is as important, if not more important, to study than failure. So let's finish talking about design. When you have a problem, how do you know that you have a problem? And from the perspective of design, for you in the OR, if you have interruptions by doing whatever you're doing, frustration, self-doubt, there are more non-routine events, you're going to have increased risk of failure. And in contrast, when there's good design, the technology is invisible. You have flow of your care. You're more satisfied. You're more confident. Recovery is more likely to occur, and there's a decreased risk of failure. How do we achieve good design? With human-centered design, which starts with a deep understanding of what frontline, we'll say clinicians, do every day, both for routine and non-routine cases, to then deliberately design the thing based on requirements, users' needs, and iterate it using simulation often, and then evaluating it before you implement it to also design the implementation, which is often, especially for software, a source of failure, and continue with post-deployment review. So with regard to medication safety, we have to look at the whole process, the people, including the patients and their family, the processes, maybe using the STPC framework that APSF developed years ago, all of those tools, and we have to understand the context because none of those alone is going to solve the problem. So my take-home messages are: one, consider the system as a whole, including culture and leadership, which is so important, and we still haven't figured out how to make that work. Even when they're broken parts and you're trying to fix them, take the big picture view. Use safety too, how things go right, in order to better understand how to make the system more resilient, more adaptable, and more likely to recover. Value and harness frontline clinician and other expertise. So when people make mistakes, the question to ask is, how many times, because there'll be many times, did this not happen because other people figured out how to prevent it from happening, and let's learn from that. Design technology so it's a well-communicating partner that helps meet users' needs during actual use, which means the engineers can't be the only ones to build something. They can't be running the asylum, as a well-known book talks about. And then one other thing is, it makes sense to standardize, but you've got to be flexible and adaptable, especially in more complex non-routine situations. So if you standardize and take all the flex out of the system and penalize people who deviate from the standardized protocol, you're going to create more risk than reduce it. So thank you very much. This is what I wish we had in the OR, a safety meter. We don't. The safety meter is all of you. Thank you.